Yeah, now I request Dr. Sunita Bamnikar to please present the SLOs in female genital tract. She was very kind enough, gracious enough to take over this. She has already presented two major SLOs in the systemic breast and again she has agreed to
GIT.
do SLOs in female genital tract. Madam,
Mm.
thank you so much. Because of you, now we are having a SLO, a webinar today. Madam, please go ahead. Thank you.
Yeah, thank you, Dr. Vinaya. Good evening, everybody. Good evening, Dr. Bedi sir. It's my pleasure. Actually, it was a lot of work in 3 days, but never mind, it's fun also. So today, our FGT competencies, I think it'll be a little pretty long session because there are 9 competencies. So friends, you all can sit back and relax while I take you all through the SLOs of these female genital tract competencies. My voice is clear, right?
Yes, madam, very clear.
Oh, okay. Our first competency is describe the epidemiology, pathogenesis, etiology, pathology, screening, diagnosis, and progression of carcinoma of cervix. The second competency, describe the pathogenesis, etiology, pathology, diagnosis, and progression of and spread of carcinoma of endometrium. The third one, describe the pathogenesis, etiology, pathology, diagnosis, progression, and spread of carcinoma of leiomyomas and leiomyosarcomas. There's some error here. I corrected that in the subsequent slide. Spread of carcinoma of leiomyomas is corrected later on. Actually, in our booklet, it is like that only. The fourth competency, classify and describe the etiology, pathogenesis, pathology, morphology, clinical course, spread, and complications of ovarian tumors. Now, these 4 competencies are all core competencies. Okay, and we will go in detail a little later. Yeah, the next competency, the fifth one, describe the etiology, pathogenesis, pathology, morphology, clinical course, spread, and complications of gestational trophoblastic neoplasms. This is again a core competency. Then the sixth one, describe etiology, morphology, morphologic features of cervicitis. Next, describe the etiology, hormonal dependence, features, and morphology of endometriosis. Describe the etiology, morphology, features of adenomyosis. And lastly, describe the etiology, hormonal dependence, and morphology of endometrial hyperplasia. Now, these last 4 competencies, as you can see, they are non-core competencies. We will come back to this when we discuss the SLOs. Just for now, I have just given our view here, like cervicitis, endometriosis, and adenomyosis. We consider this more for self-directed learning, and accordingly we will move ahead. Okay, so those are the non-core competencies. Now let's look at the SLOs of the first competency. Describe the epidemiology, pathogenesis, etiology, pathology, screening, diagnosis, and progression of CS cervix. The first SLO, describe epidemiology of cancer cervix. Then followed by describe the common human papillomavirus types that affect the cervix and describe the pathogenesis of cervical dysplasia and neoplasia. Like here, we will want them to show to describe the progression from metaplasia to dysplasia to in situ to invasive carcinoma. Okay, and then describe the clinical features and morphology, gross and microscopy of CS cervix. Enumerate the screening tests and diagnostic laboratory tests for detection of carcinoma cervix. Now, in this what we could have is an interactive lecture, and also very good videos are available also, to explain about carcinoma cervix, pathogenesis, and there should be vertical integration with OBS-GYN through this. I'd like any suggestions on this before we go to the next competency.
I can't, 1 minute. Someone, Dr. Kalpana has raised her hand. Unmute yourself, Dr. Kalpana.
Hello, good evening.
Yes.
Hello. Yeah, good evening.
I haven't raised the hand, but I have to say something. In this, we can add also the students, they will receive the report of this cervical CIN 1, 2, 3 grades. So what they understand by that, that can be added. The grading of
Yeah,
carcinoma in situ.
yeah. So I guess that should be covered in the fourth SLO, which is about
Yeah,
diagnostic laboratory tests. So
yeah,
that's
and the interpretation as
interpret.
an
We can put that into
IM.
bracket interpretation of CIN 1, 2, and 3.
Yeah, yeah.
Sure. Thank you.
Welcome, ma'am.
Okay. Shall I proceed?
Yeah, proceed.
The second competency, describe pathogenesis, etiology, pathology, diagnosis, and progression of carcinoma of endometrium. Now, our first SLO here is describe the etiology, risk factors, pathogenesis, and morphology of carcinoma endometrium. This could be an interactive lecture and also a very good case-based discussion it can be. Then the next SLO is outline the morphologic effects of oral contraceptive pills on the endometrium and possible adverse complications. This I thought we should put it separately. It is a good idea to have it separate SLO on this, although it will come in the risk factors to some extent to emphasize this importance. It can be even taken as a small group discussion. Then the third one, describe the mode of diagnosis, grading, staging, and spread of carcinoma endometrium. And this competency again should be vertically integrated with obs-gynae. Any suggestions on this?
Madam, I can't see anyone raising hands.
Okay, I'll
You
proceed.
can go ahead, madam. Yeah.
The third one, describe the pathogenesis, etiology, pathology, diagnosis of leiomyoma. I've corrected it here, diagnosis of leiomyoma with progression and spread of leiomyosarcomas. The first SLO describe etiopathogenesis and morphology of uterine leiomyoma and leiomyosarcomas. This can be an interactive lecture or even a case-based discussion with integration with OBGY. Then a separate SLO is there, which says compare and contrast the clinical and pathologic features of uterine leiomyomas and leiomyosarcomas. This is good this is a good exercise for them to compare this benign and malignant tumor, we thought. Then the third one, enlist laboratory diagnosis, progression, and complications of leiomyomas and leiomyosarcomas. So this is all for this particular competency. Then the next one, the fourth competency, classify and describe the etiology, pathogenesis, pathology, morphology, clinical course, spread, and complications.
Dr. Kalpana has raised her hands.
Okay, shall I go back to the previous one?
No, sir.
Dr. Kalpana, you want to say something?
Sir, I have already commented in carcinoma for the cervix.
Madam, you can your raised hands now. You can click on that. So your hand is always
Okay.
okay, madam.
Okay. So for this our competency on ovarian tumors, we have these SLOs. First, to begin with, classify ovarian tumors. Then,
Dr. Malini has raised. Dr. Malini has raised. Ma'am, you want Malini?
Unmute yourself, madam.
Yeah, I have unmuted myself. This was regarding the previous one on the leiomyomas and the leiomyosarcomas. The previous
yeah.
SLO on that, how much of detailing do we do about leiomyosarcomas? Because for us sitting in pathology itself, I think leiomyosarcomas always are a doubt all the time. So how much of it do we actually teach the undergraduates? Because if you're using that as an example between a benign and neoplasm, how further would we go with undergraduates on a leiomyosarcoma? No, I was not very sure. That's why I'm asking that.
Actually,
Yeah, Dr. Vinay, go ahead.
actually, madam, leiomyoma is the most common tumor we teach them even when we take the neoplasia lecture.
Huh.
And leiomyosarcoma, to some extent, it is enlisted along with soft tissue tumors. But here, what we can show gross morphology, it's well circumscription, and leiosarcomas are highly, morphology. On gross morphology, we can just tell them this has a lot of hemorrhage and necrosis. Here, it is very well demarcated. So that part only we can tell them, and at the same time, we have to tell them leiomyosarcomas are very, very rare. And another thing we have to tell them, it is not that leiomyoma is a precursor to leiomyosarcoma. That concept also has to go into their brain and head, because leiomyomas are most common in a reproductive age group. And so that thing will give us a platform to emphasize the rarity of leiomyosarcoma into FGT. The gross morphology can be emphasized, and at the same time to tell them, please remember, leiomyomas are not precursor to leiomyosarcoma. Sarcoma, that entity is used because it is a mesenchymal tumor, and that simple that thing can be yes, madam,
No. My only doubt was that wouldn't taking leiomyosarcoma, I don't know whether that would be a good example to actually differentiate between benign and malignant. That was my query there actually. Because you can have a well circumscribed leiomyosarcoma, right? Which is why we put multiple bits even in a leiomyoma. That was the only question. That was my doubt.
Yeah, madam, that it's necrosis and hemorrhage. Yeah.
And besides the students.
Hello. Yes.
Hello.
Yes.
Yes. Good evening, sir.
This 33.1 and 33.2. What is the difference in these two lectures?
30.3.
Describe morphology, gross and microscopy, leiomyosarcoma, and compare and contrast clinical pathology, uterine leiomyosarcoma. So what is the difference?
There isn't much difference, but it is kind of overlap definitely over there.
So then why we take two lectures then?
No, not lectures, sir.
No, we're not taking two lectures. It is not two lectures. Do not go by the every where we have written the interactive lecture doesn't mean a 60 minutes lecture for each of those. It's not that way.
In 33.1, you can tabulate differences between leiomyoma and leiomyosarcoma.
We can put it compare and contrast. Those two words we can put it in brackets in the first one. Sure.
How much leiomyosarcoma we are going to pick undergraduate?
No, we don't see, sir.
But all these years, I think we have been. This is the only tumor in female genital tract that we have been teaching. I think carcinoma cervix and leiomyosarcomas. So, and that is why it is, I think, come up in the competency.
Okay.
Actually, in the traditional pattern, we never taught them leiomyosarcoma. Only in this competency test come. So we can
yes. As one of a malignant tumor, it's good, correct. I think. Yeah, and plus they also students are expected to know a little bit about the malignant cell and a benign cell, what it is, leiomyoma and leiomyosarcoma. It's also expected. Okay. Yeah, the next one on ovarian tumors. The first one is classify ovarian tumors. Describe the causes of ovarian neoplasm, including the risk factors, genetic associations, and molecular basis for ovarian neoplasms. Here, this one, we should integrate it with obstetric gynae when it comes to ovarian tumors. The third one is describe the clinical and pathologic features of surface epithelial tumors. Describe the origin, clinical, and pathologic features of germ cell tumors. followed by describe the morphology and complications of benign cystic teratoma and immature teratoma, and describe the clinical and pathologic features of sex cord stromal tumors. I think here we can also add list the sex cord stromal tumor, but no need. I think it comes in classify the ovarian tumors. That's fine. So, and then the last one is list the common primary malignant tumors which metastasize to the ovary and describe the clinical and pathologic features of Krukenberg tumor. Now, in this again, a lecture will cover the ovarian tumors and integration with obstetric gynecology. There can be very good case-based study, case-based discussion with ovarian tumors. Any suggestions?
Uh,
I'll proceed.
I think so. Yes, Doctor. Sir, you want to say something, Dr. Lanjewar, sir? Because hand is raised, sir.
Dr. Vandana Agarwal.
Hello.
Yes. Hello. Yes.
Hello.
Doctor.
Good evening, ma'am.
Good evening.
Ma'am, in this first SLO classify ovarian tumors, can we just modify, make it the WHO classification of ovarian tumors?
Yeah, we can do that. Do we expect our UGs to know the WHO ovarian classification by heart?
Because most
That's
of
why I didn't write it there.
the question which comes in the university exams is written as ki give the WHO classification of
WHO
the
classification. Okay.
Yeah.
Put it. Yeah.
I don't know, Dr.
Okay,
Sunita. I don't remember ever asking the question as per WHO classification. Give the this
Even I don't remember anywhere asking like
because
that
we
because
do not set
it's a
it
big
that way.
classification. It's a huge classification
Yeah,
by WHO. So whether the students
and
expect
WHO nowadays are also including molecular and many other things which they are not supposed to know.
absolutely,
Basic
absolutely,
classification, jo,
yeah.
that they should know.
Can I just say something?
Yes, yes.
I think, yeah, I think probably it may be better that we stick to the WHO classification because we can use the broader classification, right? We don't have to go into the details of the classification, but the broad categories probably is better to use the WHO because like what Dr. Vandana said, there are times when question comes as WHO classification. So I think it may be probably because that is the standardized classification. Probably it may be better that we tell them the WHO classification, but not going into too many details. So the broad categories probably.
We can write it in bracket, broad category or
Yeah,
WHO.
yeah, oh yeah, I think so because I think we need to tell them this is how it is being categorized now.
Okay.
Yeah, thanks. Thank you.
Is that okay?
Yeah,
Yeah.
thank you.
Yeah. All right. Anything else?
Yes, please.
Yeah, go ahead. I don't think so. Yeah. Dr. Sunita, go ahead.
Go ahead. Okay. The next, the fifth, the competency, describe the etiology, pathogenesis, pathology, morphological, clinical course, spread and complications of gestational trophoblastic neoplasms. Now, it is written as neoplasms, okay? They don't even say it as gestational trophoblastic disease, really. So we are in, if you have to go strictly by this, then we will only be talking of choriocarcinoma and trophoblastic implantation tumor. So we have, first of all, given here first SLOS, describe placental histology and classify gestational trophoblastic diseases. Okay. Then the next SLOS mention, define hydatidiform mole, describe the etiology, pathogenesis, morphology, and clinical presentation of hydatidiform mole. So some of my colleagues mentioned that we can write here, how will you announce and counsel a young expecting mother about the diagnosis of vesicular mole and do it like kind of a role play. I do not know what the audience think about this, whether we should be doing that. And the third SLO is define and describe the incidence, morphology, clinical features, laboratory findings, and complications of gestational trophoblastic disease. So this is how we have tried to cover this competency. I would like your suggestions, please, use on this.
Any suggestion? Actually, madam, about this, how will you announce and counsel?
Yeah,
we have some
yeah.
AdCom module in second professional year. Certain amount of hours are allocated. So in that, certain things like genetics also.
Yeah.
In genetic also we have a lot of counseling, prenatal and natal, antenatal counseling, all that.
Yeah.
So in that,
So we could use
we
this.
can form core SLOs or core competencies in that. Some we have to have, na, that AdCom module is
Yeah.
already out, and they have already
Yeah.
defined 1 year, first year professional should have covered this, second professional should cover this. So in that we can, so many hours, because when we three
Yeah.
subjects have to divide among ourselves, 3 or 4 subjects of all of us.
Yeah.
Bioethics is there in that and all that. So this can be a
Yeah.
part of it, madam. So that's what
Part
I
of AdCom model, but not here,
Yes.
right? We can put it, if we can consider this definitely for the AdCom module.
I think so. Yeah. There, when we are doing that, this can be kept in
Yeah.
mind. Here, asterisks can be
Sure.
put and later on to be, incorporated there. Yeah.
Okay. Okay, shall I go ahead?
Anyone raising hands? No, sir. Lanjewar sir, his hand is raised, but Vandana,
No,
you want to say
continue.
something? Continue, bol rahe, sir.
Yeah.
Okay, continue. Dr. Sunita, continue.
Yeah. Yeah. Describe the etiology and morphologic features of cervicitis. Now, the cervicitis, they have taken a separate competency. Classify cervicitis and enumerate the etiologic factors of cervicitis. This, I think we can take it as a self-directed learning. Discuss the common human papillomavirus types that affect the cervix and discuss the pathogenesis of cervical dysplasia and neoplasia. To some extent, this is already covered when we do CS cervix, but because it's a cervicitis competency, this has come here again. Describe the cervical screening methods and preventive measures for cancer cervix. Again, we can take that as a self-directed learning or even a small group discussion. This can be considered for with vertical integration with OBGY.
I can't see any raised hands. Go ahead.
Okay. The seventh competency, describe the etiology, hormonal dependence, features, and morphology of endometriosis. Here, the first SLO is define endometriosis and enumerate various sites by endometriosis. This can be a self-directed learning. Again, discuss the pathogenesis of endometriosis and mention the clinical presentation of endometriosis. Discuss morphology of endometriosis with reference to chocolate cyst of ovary. These are non-core competency.
There are no raised hands, but I don't know why it is non-core, because endometriosis is a and chocolate
we will
cyst,
come
very
back to
commonly
this.
encountered surgical
Absolutely.
specimen. Huh?
Yes, yes. We will come back to this. There are some suggestions we have made towards the end. We'll come back to that.
Achha, okay,
we'll
madam.
some
Yeah.
things later on.
Okay. Yes, madam.
Third, the eighth competency, describe etiology and morphology of adenomyosis. Now here, first SLOs enumerate causes of abnormal uterine bleeding in premenopausal and menopausal age group. Again, this is a non-core competency, but what Dr. Vinay has also suggested is that we could take this as a case-based discussion for DUB, dysfunctional uterine bleeding, and wherein we can kind of cover the adenomyosis and endometriosis. Define adenomyosis, describe its morphology and clinical presentation, describe endometrial polyps, compare and contrast endometriosis and adenomyosis in terms of incidence, clinical presentation, pathogenesis, morphology, organs involved, and complications. Now, again, this could be a repetition in because it will have covered here. If we wish, we can take this SLO out if you think this is already covered here. Any suggestions?
I think so. It gets covered. We can remove it because then
Yeah.
yeah.
Because this is just, I have seen a lot of competencies and SLOs which they have described, and they have always mentioned this compare and contrast. That's the reason I added in this. But
No, compare and contrast is a higher level application based this, madam.
exactly, yeah. So it
So
is
this
good,
has
no?
to be
That's what we want our students to know.
yeah.
I think it is
It's
good.
like what are the different features, vagara tabulate. So compare contrast is really high level
True,
cognitive.
true.
Yeah.
So I really like to keep it for that reason.
Yeah. Okay, madam.
Yeah. The next one. The last competency, describe etiology, hormonal dependence, morphology of endometrial hyperplasia. It is pretty surprising that this is kept as a non-core competency. But we suggest that I think there should be a core competency. The SLO here will be describe the phases of menstrual cycle and associated hormonal changes and enlist common causes of abnormal bleeding in adolescents, perimenopausal, and postmenopausal women. This is kind of same, like it could be a case-based discussion with for dysfunctional uterine bleeding, where which will have covered in endometrial hyperplasia. And then the next SLO is discuss the clinical and pathologic features of the following endometrial processes: atrophy, hyperplasia, and polyp. And define endometrial hyperplasia, describe its etiology, classification, and prognosis. Or rather complication. We can mention complication instead of prognosis.
Yeah.
Complication. So this should be a core competency. We will come back to this. Yeah, the last three competencies, we have a little suggestion to make, and I'll tell you that very soon. Shall I proceed?
Yes, madam. I'll see. Okay. Dr. Vandana, you have raised your hands. You want to say something? Unmute yourself.
No, ma'am.
Okay.
Yeah, now after seeing all those competencies, all the 9 competencies, what we think is there should be 3 lectures for female genital system. In one lecture, what could be covered is diseases of the uterus, in which we cover cancer cervix. And when we do cancer cervix, we are already covering precancerous risk factors. So we are covering cervicitis, HPV, and so on. Endometrial cancer, in which we will have to talk about precancerous risk factors. So we will cover endometrial hyperplasia. Leiomyoma, leiomyosarcoma will be covered here. Okay, so this lecture 1 will be that. Whereas adenomyosis, endometriosis could be either self-directed learning or a case-based discussion on dysfunctional uterine bleeding should cover that. Second lecture could be on ovarian tumors, and the third one on gestational trophoblastic disease. Again, I have called it disease here, although the booklet says neoplasia, gestational trophoblastic neoplasm. So that's the correction we have done. What we see is there is no mention of disorders of fallopian tubes, alpingitis, pyogenic and tuberculous tubo-ovarian mass, which we talk so commonly. That is not mentioned. Ectopic pregnancies, there's no mention. Ovarian polycystic disease, there is no mention. And these I feel are important. And so if you all agree, then we could incorporate, to include this, we could incorporate in competency 30.4 of the ovarian tumors. We could incorporate these 2 SLOs. Describe polycystic ovarian disease in terms of clinical presentation and morphology. enlist the pathogens, bacterial, fungal, parasitic, that can cause tubo-ovarian disease, and describe the mechanism, clinico-pathologic features, and complications. So this is what we propose or suggest to complete the disorders here in female genital system, to include in 30.4, if you all agree.
It looks fair enough, madam. Actually, it should be. This looks fine. Anyone? Sir, Dr. Lanjewar, want to say something, sir? Sir, unmute yourself. Dr. Malini, please unmute yourself. Dr. Malini, you have raised your hand. Please unmute. Dr. Lanjewar, sir.
Continue.
Continue.
Vinaya, continue.
Okay, sir.
Now, other thing what I noticed is
Okay,
there is
sorry. Can I just interrupt because I was not able to unmute myself? I think
Okay.
the organizer had. Just one query that I had was you said that the endometriosis was not mentioned as part of a competency, right? So that was
no,
not mentioned as
endometriosis
part
is
of.
there. It is there.
It's not.
As a
It's
competency,
there,
it
but
is
not
there.
a core competency.
Yes.
Yeah. So can we club endometriosis with ovarian tumors, because it's like a precursor lesion, no, for the ovarian tumors? So can we bring the endometriosis, highlight the importance of endometriosis there, so that you get more time for your PID and your the pelvic inflammatory disease, which may be of more clinical significance also? Can we do it like that?
But ovarian tumors itself is pretty vast, I think.
But you will anyway be mentioning the risk factors, no? So in that, wouldn't it be possible? No, I was just thinking as because that is the importance of the endometriosis part of it, other than the clinical significance. So would it be possible
because
when we talk
it does
about
not come
precursor?
with neoplasm, no? It will not. It's not. It will mix up with the neoplasm. We're talking about ovarian neoplasms, and then include
as in
endometriosis.
precursor lesions, like whatever is like a risk factor for.
Which
endometriosis is not
I
a
don't
risk
think
factor.
endometriosis is a risk factor.
It is just
You can have.
no, madam.
You can have with
It is
clear
like
cell
if it
tumors
was
clear
only
cell
ovary,
tumors
it
and
rise to chocolate cyst, madam.
no.
Because there are a lot of
As part of
mechanisms
clear
of
cell.
endometriosis. Mechanisms have to be
That's
assigned
okay.
to them. So
That
that
is
we can do
okay.
through case based and separate case or some small group.
Okay, I don't know. I thought part of your endometrioid and your clear cell tumors of ovary, I thought endometriosis was a precursor lesion, right?
No,
That is what the current
No.
concept is.
No.
I don't think so.
Oh, I am not. I think that's what WHO says. Anyway, I'm not the expert on it, so we'll get somebody who's the expert on it to comment on it. That was my understanding.
Hello.
Okay, madam. I will.
Hello.
Hello.
Hello. Madam,
Hello.
how many lectures are allocated for female genital tract?
We are proposing 3 lectures: lecture 1, lecture 2, and lecture 3.
Yeah, madam. But in lecture 1, I think these topics cannot be covered in one lecture. All of them.
Yeah. Provided cancer cervix, endometrial hyperplasia, leiomyoma, leiomyosarcoma. This is what we will have to take in that lecture. Just this.
It will be very difficult to cover the points.
It is up to us. We can allocate more lectures. It's
in practical, we can take something.
Yeah, practical we have to.
Yeah, I'm coming to that in the next slide.
Yeah. Okay. Ovarian tumor is also very difficult to complete in one single lecture.
Yeah.
That's true.
That is to be also covered in the practical class. Cysts, we are giving them slides of cysts in this thing, then benign benign teratoma, and that's how we will complete it. No? benign cystic teratoma, dermoid cyst, we are giving in the histopathology. There we have to teach them more.
Yeah.
Okay, we have to adjust the
Can we
time
proceed with the
between
next one?
practical and theory.
Yeah. Yes, madam.
Yeah. Okay, thank you.
No, as we saw with the competencies, we note that there is no dope session allocated in female genital system. So what I suggest is to incorporate dope session in 30.6. That is, that cervicitis competency, a big competency for cervicitis, which cervicitis will be covered when we are doing CA cervix and mention about the HPV types and precancerous lesions and so on. Or either incorporate or replace the cervicitis with a dope session, and in which we should
Demonstrate assess
students
performance.
should be able should be shown gross specimens and images and microslides of basically these lesions: carcinoma cervix, carcinoma endometrium, leiomyoma, leiomyosarcoma, and cystadenocarcinoma teratoma. Spelling error here. Teratoma. These are the lesions we have been showing students all these years, whether the MCI feels it is not necessary now to show all this, that's why they're not included dope, or whether they have just missed it by, I don't know. So if you agree, then this is what we can do by incorporating this dope session in 30.6 on cervicitis lesion, which is towards the end of the competencies.
I think so. We have to incorporate this, madam. It must be overlook, I feel. And these specimens, what we have to show them, it's very easily available because they're all surgical specimens.
They're common. They're common.
They're common and surgical specimens. So institute will be
Yes.
getting that, and they
Yes.
come here for grossing to pathology department. So there is no scarcity of the
Yeah.
specimens as such. So we
Yeah.
can have that plenty, and small groups. Each group can be shown the specimens in this. So I think so. It should be there.
True. So I will add this one more SLO in 30.6 for a dope session, and then I will say show how, and yes for that, right?
Yeah.
Cool.
Anyone wants to say anything? Dr. Tamil Selvi, madam, you have unmuted. You want to say? Dr. Vandana, your hand is raised. Hello. Hello.
Hello.
Hello, madam.
Ma'am, I don't. It is showing my hand is raised. I have not raised my hand.
Okay, it shows raised. Okay. Then Dr.
Okay.
Tamil Selvi, madam. Yeah, madam. No, you're not. Very feeble, madam. Raise your voice, madam. I can't hear you.
No.
No, madam. We can hear you. It's very feeble, madam.
Come closer to the laptop. No, your microphone is down. Right in the WhatsApp group.
Shall we proceed?
Dost Mohammed Khan.
Yes, sir. Good evening, sir. Ma'am, can we have this auspice session regarding to leiomyoma, sarcoma, and ovarian tumors?
Sure. Yes, that is up to us. So that is why in the dope session, auspice can be easily taken on this, on these tumors. Definitely.
Okay, okay. Yes, thank you, ma'am.
So Dr. Bedi sir, is this okay to incorporate a dope session in 30.6 competency cervicitis? Because that is completely
I think
absent.
we can, but I mean, but for that, I mean, I think we have got sufficient material to show them the gross specimens.
Yes.
I mean, it can be done.
Yeah.
In every department, there are sufficient specimens.
Yeah, these are common specimens. They can definitely be shown.
Yes.
Okay. So, shall I go?
Okay, madam.
These are some reading resources, and then I have picked up some video links here, which for each of these conditions, nice videos are there for educational, pelvic inflammatory disease, endometriosis, cancer cervix, ovarian cysts, uterine fibroids, ovarian tumors, ovarian germ cell. So they are quick 5-6 minute videos, very educational for students. Just add it to this list. Then then the CBDs, case-based discussion. So now we have about 10 case-based discussions and some around 40 MCQs, which we can go a bit fast on the MCQs. Let's see the CBDs. A 26-year-old woman has had intense vulvar and vaginal pruritus, along with a thick, cheesy vaginal discharge. There is no noticeable odor. A wet mount of vaginal fluid is shown here. What is the most likely diagnosis? What special stain is used here for staining these organisms? So this is what. Now, our competency nowhere has mentioned anything about vaginitis, well, trichomonas, candida, nothing, nowhere in the competencies it is there. But this is so important, I felt that we need to include it somewhere. So during small group discussions, we have to introduce this when we tell about cervix, mention these conditions also. A 42-year-old lady presented with low abdominal discomfort and urinary symptoms. Describe the specimen and identify the lesion. Further question on the same case. Is this tumor benign or malignant? Name 2 clinical presentations of this condition and describe the microscopic morphology you see here. So that's how this will go. The third one, female of 63 age, had lower abdominal discomfort and urinary symptoms. There was a palpable mass in the pelvis that on imaging was seen to be uterine in origin. She underwent hysterectomy and bilateral oophorectomy. So describe the gross specimen. Both the cut surface and the intact specimen is shown. This is to show the uniform enlargement of the uterus. So what is the most likely diagnosis? What is the cell of origin of this tumor? And which immunohistochemical marker can be used to confirm the cell of origin of this tumor? That way. Here describe the microscopic morphology. So here the necrosis is pointed out and the nature of the cells. So we expect them to know a little bit of this. A 23-year-old female was found to have a cervical lesion 3 months previous to this admission. The biopsy revealed carcinoma of cervix and the uterus was removed. So describe the specimen. So the entire external cervix is a fungating mass. Give a microscopic description of the H&E section. And then what is the diagnosis? Familiarize them with the squamous carcinoma here. Again, in the same case, we can ask what risk factors for the above condition, what is the most efficient way to diagnose this condition, and then which of the following statements about this tumor are true. It may present at any age of life from second decade onwards, related to HPV infection, fungating tumor in the cervix, 95% are squamous carcinomas of large cell, all of the above, none of the above. Sorry. So that will be the case based on PA cervix. The next one, 58-year-old female whose uterus was removed for uterine prolapse and urinary incontinence. So this tumor, both the HNE and the cross specimen is shown. Tumor arises from endometrial cells, smooth muscle cells. So this is what we want to ask. The diagnosis is uterine leiomyoma. In the pathologic assessment of this sort of pathology, there is nuclear atypia and giant cells are not compatible with benign tumor. The distinction between leiomyosarcoma and leiomyoma is based on nuclear atypia, mitotic index, and necrosis. Malignant transformation of leiomyoma is common. Subserosal leiomyoma is the most likely cause of menorrhagia. So select the best answer. What is the risk of malignant transformation of these tumors? So we were discussing about leiomyoma, sarcoma. So these are the important points we want the students to know. This 50-year-old female complained of lower abdominal pressure. A mass was palpated on pelvic examination. So describe the specimen. Describe the microscopy section of the above specimen. What is the most likely diagnosis? Okay. This type of ovarian tumor arises from ovarian germ cells, shows prominent proliferation of fibrous stroma, tends to occur in middle adult life, rarely after menopause, is associated with Meeks syndrome, may result in precocious puberty. Which of the following statements about ovarian mucinous tumors of borderline malignancy are true? So those are the options. Peutz-Jeghers syndrome, Samoma bodies, nests of transitional cells are associated with Schiller dual bodies. Bilateral tumors are often associated with mucinous neoplasm of the appendix. That's about this case. The next one, a 25-year-old woman came with history of dull abdominal pains in 6 months. On physical examination, a right-sided adnexal mass was noted. CT pelvis showed a circumscribed mass, the right ovary with calcification. Mass is excised. What is the most likely diagnosis? And enumerate the tissues that can be seen on microscopy. And then, can this lesion undergo malignant transformation? If yes, which is the most common malignancy? So this covers a dermoid also. The next one, a 35-year-old woman came to the hospital with complaint of increasing abdominal distension since 6 months. Her menstrual cycles were regular. On examination, abdomen was distended with fluid wave. Pelvic USG revealed bilateral ovarian cysts and surgical excision was done. What is the most likely diagnosis? Okay. What is the lining epithelium? What is the diagnosis now? And what are the calcific bodies that can occur in serous tumors called? A 20-year-old woman is in the second trimester and develops vaginal bleeding. A dilatation curettage is performed. What is the most likely diagnosis from the gross specimen? What is the typical clinical presentation in such a case? And then which laboratory test is done during the follow-up of these patients? What is the clinical significance of this condition? The last case-based discussion. A 50-year-old obese nulliparous woman complains that her menstrual blood flow is more abundant than usual. Ultrasound reveals a thickened endometrial strip with polypoid mass. The patient undergoes hysterectomy. Uterus is opened and the necrotic mass is seen in the image. Biopsy of the mass shows moderately differentiated adenocarcinoma. Which of the following represents the most likely precursor of this patient's malignant condition? For the same case, neoplastic cells obtained from the patient described in this would most likely show loss of function of which of the following cell cycle control proteins? So now that brings us to the some MCQs on female genital tract. I do not want to bore you all, so I will go a little fast with the MCQs. Some are simpler, some are a bit more clinical story on that. Pap stain is commonly used for the detection of early cellular dysplasia in tissue scrapings from the uterine cervix. Chronic pelvic inflammatory disease is most often initiated by which of the following organisms? Neisseria gonorrhoeae, chlamydia. The most common uterine tumor is leiomyoma. Endometrial carcinoma may be caused by which hormone? Estrogen. The most common primary malignant tumor of ovary is cystadenocarcinoma. The hormone that is directly responsible for the production of secretory changes in endometrial glands is progesterone. Studies of cancer of the cervix strongly indicate that sexual transmission of an oncogenic agent as the cause. What is this agent? All of the following are true about cancer of the uterine cervix, except as a peak incidence about after menopause is detected in early stages where PAP appears to be associated with multisexual partners and progress from dysplasia to carcinoma in situ to invasion. So has peak incidence after menopause is the correct answer. A woman from Asia has increased levels of beta HCG. She recently had a pregnancy and it was a mole. The structure was hemorrhagic friable with no chorionic villi. Which of the following are key features of her disease? Whether it is malignant cytotrophoblast, in situ trophoblast, cured with chemotherapy, extensive metastasis, all of the above. Okay. A woman presents with amenorrhea, vomiting, and positive for pregnancy test. 3 to 4 months later, she has vaginal bleed with grape-like structures present. There are also fetal parts present. The most likely chromosome for her mole is 69XXY. Which one of the following endometrial lesions is associated with the highest risk of developing endometrial carcinoma? Complex hyperplasia with atypia. This is just an explanation for the MCQ. 36-year-old gravid female notes vaginal bleeding. Ultrasound reveals a small grape-like cystic structures without evidence of developing embryo. Diagnosis of complete hydatiform mole is made at the hospital. Further analysis is most likely to reveal that HCG levels are markedly raised, serum levels of alpha-fetoprotein are elevated, genotype is 46XS and is completely paternal in origin. Genotype of mole is triploid or 2 or more sperm fertilized the ovum. So that is the correct answer. Genotype of the mole is 46XS and is paternal origin. This is again explanation for the previous question. This is again explanation for the MCQ. 13, this is a little kind of a match the column. For each types of ovarian tumor listed on the left side, the most appropriate associations on the list on the right. Cystic teratoma, granulosa cell tumor, mucinous adenoma. So cystic teratoma, benign tumor of germ cell origin. Granulosa cell tumor may cause endometrial hyperplasia. Mucinous adenoma can lead to pseudomyxoma peritoni. One more match the column. Choriocarcinoma, ectopic pregnancy, and hydatidiform mole. Choriocarcinoma, beta HCG elevated. Ectopic pregnancy may occur with an intrauterine contraceptive device, inside, and hydatidiform mole, atypical trophoblastic proliferation. MCQ, stroma ori is composed of which of these? Mature thyroid tissue. Endometrial cancer is associated with intrauterine contraceptive device, associated with excess estrogen, has obesity as the risk factor. Clear cell carcinoma is the most common, associated with HPV infection. So the best option here is associated with excess of estrogen. A 54-year-old woman with an abdominal mass undergoes exploratory laparoscopy. Both ovaries are enlarged and hence resected. Pathology report is Fruchtenberg tumor, indicating which of the following? Ectopic pregnancy, endometriosis, immunosuppression, metastasis, or hyperestrogenic state. You obtain a routine pap smear while performing a physical examination on a 28-year-old female. Gross inspection of the vulva, vagina, and cervix reveals no apparent lesions. The results of the pap smear are consistent with cervical intraepithelial neoplasia 2. What is the major significance of this finding? Cervicitis needs to be treated. She has increased risk for cervical carcinoma. Condyloma acuminata is a probability. An endocervical polyp needs to be excised, or she needs to discontinue oral contraception. Increased risk of cervical cancer. So it tests the risk factors knowledge from these students. A 58-year-old female has had dull pain in the lower abdomen for the past 6 months, along with some minimal vaginal bleeding on 3 occasions. An abdominal ultrasound reveals an 8 centimeter adnexal mass. Abdominal hysterectomy is performed and the mass is diagnosed as an ovarian granulosa theca cell tumor. Which of the following additional lesions is most likely to be seen in the surgical specimen? Endometrial hyperplasia associated with this tumor. The malignant surface epithelial tumors of ovary include which of these? Mucinous adenoma, stromal tumor, sarcomatoid tumor, squamous carcinoma. Which of the following facts about carcinoma of cervix are incorrect? 90% are adenocarcinoma associated with HPV. Common presentation is intermenstrual vaginal bleeding. Cervical erosions may be seen on speculum examination. Disease may not present until the advanced stage. Okay, next one. Which of the following is not a risk factor for ectopic pregnancy? Pelvic inflammatory disease, pelvic surgery, adhesions, IUCD, progesterone pill, previous cesarean section. A 36-year-old sexually active woman has noticed that vulvar lesions have been increasing in size and number over the past 5 years. On physical examination, there are multiple 0.5 to 2 centimeter red, pink, flattened, rough lesions on the vulva and perineum. One of the larger lesions is excised and the figure is shown. Which of the following infection is most likely to produce this? So we want them to appreciate the coilocytosis caused by human papillomavirus. Most common origin of Fruchtenberg tumor. Is this the correct answer? Most common origin of Fruchtenberg tumor, breast or gastric?
I think so. It is gastric, madam. I don't think so. It's breast.
I think it is gastric. That too. Yes,
Yeah.
I will take that. Then a woman presents with amenorrhea, vomiting, and positive for pregnancy test. 3 to 4 months later, she has vaginal bleeding with grape-like structures present. There are also fetal parts present. The most likely chromosome for her mole is 69XXY. A 36-year-old woman presents with infertility. She complains of having a dull pelvic pain for 9 months, which is accentuated during menstruation. Physical examination and endocrinology studies are normal. Laparoscopy reveals small hemorrhagic lesion over the surface of both ovaries and fallopian tube and abundant pelvic scarring. So all this story, the student should be able to appreciate, clinical, that's what clinical oriented helps. Which of the following is the most likely diagnosis? So this in endometriosis, this would be covered. Next, a 30-year-old woman presents with 5 months history of increasing abdominal girth and pelvic discomfort. Imaging studies reveal a mass replacing the left ovary. A multilocular tumor filled with thick viscous fluid is removed. On microscopic examination, the tumor spaces are lined by columnar epithelial cells showing no evidence of atypia. There are no papillary structures, no stromal invasion. Which of the following is the most appropriate pathologic diagnosis? I think it's a good picture with the cysts out there. A 28-year-old sexually active woman undergoes a routine checkup. Pelvic examination reveals no abnormal finding. A pap smear is obtained and a cytopathology report indicates the presence of severely dysplastic cells. A cervical biopsy taken subsequently shows the following. So what is the diagnosis? So for them to appreciate the full thickness involvement of the epithelium, CIN3. What is the lesion shown here? Placenta, chorangioma or placental angioma is what we want them to pick up. A 22-year-old woman passes grape-like masses of tissue per vagina in 16th week of her pregnancy. She had not felt any fetal movement. On physical examination, 18 weeks in size. She measures 18 weeks in size. DNC is performed and 1000 cc of 0.5 to 1.5 centimeter fluid-filled vesicles are seen. Microscopic examination of tissue shows large avascular villi with trophoblastic proliferation. Which of the following is the best method to employ for her follow-up care? So in this, the student should be already knowing the diagnosis and then he will be able to tell about the follow-up care. Serum beta HCG estimation. A 15-year-old girl has had irregular menstrual cycles for 5 months. She had menarche at age of 13. There are no abnormal physical findings. An endometrial biopsy is taken on post-ovulatory day 9 and shows proliferative phase endometrium. Which of the following is the most likely diagnosis? Adenomyosis, adenocarcinoma, ovarian thicoma, and ovulatory cycle. Okay. A 33-year-old woman has infertility workup. Her BMI is 32. Her hirsutism is noted. On pelvic examination, bilateral adnexal masses are palpated. Transvaginal ultrasound shows normal-sized uterus, but the ovaries are enlarged and have a dozen peripheral echogenic follicles. Laboratory studies show hyperglycemia and increased androgenic steroids. For which of the following condition is she at great risk? Endometrial hyperplasia. A 20-year-old woman presents with episode of lower abdominal pain. Ultrasound examination shows a 5 centimeter cystic mass in the region of the right ovary with calcification. The tumor is removed and surgical specimen image is shown. What is the diagnosis? Mature teratoma. A 20-year-old woman has had irregular menstrual bleeding for the past 6 months. On physical examination, there are no abnormal findings. Laboratory studies show negative pregnancy tests. DNC is performed and microscopic examination shows dysynchronous endometrial glands and stroma of anovulatory cycles. Following the procedure, she ceases to have menstrual bleeding. Which of the following is the most likely diagnosis? This perhaps may not be for undergraduate, this question. It's up to us, we can reserve it for our postgraduates. To fill in the blanks here, postcoital bleeding is associated with sarcoma botryoidis is an embryonal rhabdomyosarcoma seen in less than 5 years old kids, which looks like a bunch of grapes hanging in the vagina and is highly malignant. Which of the following statements about endometrial hyperplasia are true? Are true? Characterized by decrease in glandular to stromal ratio, linked to prolonged progesterone stimulation of endometrium. P53 inactivation is seen in 63% of pre-malignant endometrial hyperplasia and about 50 to 80% of endometrial carcinomas. Complex atypical hyperplasia features crowded glands with cell stratification, nuclear enlargement, and frequent mitosis. Low-grade endometrial hyperplasia is associated with luteal phase insufficiency, all or none of the above. So basically, complex atypical hyperplasia features crowded glands with cell stratification and frequent mitosis. I think that is the end of the MCQs, and there are just for examples to complete it, I have added few short essay questions and long answer questions which can be used. And may I thank you all for your attention, and very sorry if it has been boring with the MCQs.
Yeah, I just want to say Dr. Tamil Selvi, she sent SMS, WhatsApp me. Good evening, ma'am. In the cervix chapter, competency, add staging of say cervix in FGT.
It's not mentioned. It's not there.
I don't know. Must be. And we can take 4 to 5 lecture classes according to her. 1 lecture on cervix, 2nd lecture on endometrial lesions, including endometrial carcinoma, 3rd lecture on ovarian tumors, and 4th gestational trophoblastic diseases. This is, I'm just reading her WhatsApp message.
So 4 lectures, she says. Yeah, 3 to 4, 5 will be difficult. 3 to 4 that can be, yeah.
And Dr. Indu has written, shouldn't endometriosis be core competency? Yeah,
it should
we
be.
want it to be core competency, but MCI is not suggesting it.
Yeah. So now, how do we continue to writing it as non-core, or shall I make it from N to yes now? I'm not sure what we do that now. At our end, do we just make it as yes?
Then you can write N as above as per MCI, and we Y R. I mean highlight it and Y. When we see no above first, that means it is from MCI document, and Y is yeah.
Okay, yeah, will do.
Anyone wants to say anything? Any feedback?
Thank you all for this. Actually, this was possible with a lot of input from Dr. Vinaya, Dr. Vandana, Dr. Uma Rani. Long time back, she may have put in some of her MCQs, and that was helpful for me to really make it fast because of that.
Dr. Indu Nair has raised her hands.
Yes.
Hi, Indu, say something.
Hi. One query regarding the MCQ, regarding the endometrial cancer in MCQ. One of the, two answers were given. One is high estrogen, and another one is obesity. Aren't both risk factors for endometrial carcinoma? So
yeah, obesity is also, yes, that is true.
Yeah.
Yeah. Both obesity is also a risk factor. All right, we will put it as both correct there.
Yeah, thank you. Yeah,
thank you.
Thank you, Dr. Sunita, for a very extensive and complete. The whole is covered, comprehensive and very excellent. Over to you, Dr. Sanjay. And actually, this Friday we are going to meet again at 7 o'clock. And Dr. Prasad is not there today in the webinar. He will mostly be taking on hemolytic anemia and aplastic anemia.
Yes.
Okay.
And please inform everyone that henceforth, I mean, all sessions will be in the evening. The morning session we are, because everybody is busy in some work in the college. So now the sessions have shifted to evenings.
Yes, I think evening it has worked really very good, at least for me, because afternoon is really busy in the department.
Yes,
So
everywhere now.
not very nice.
It was started during lockdown times when everybody was at home,
True.
but now it's not working. I mean, the afternoon.
Yes. Thank you, sir.
Thank you,
Yes.
sir. Thank you, ma'am.
Thank you.
Thank
Thank you, everybody.